paske li ok pou pa ok. Paske pale kapab ran bagay yo miyo. Paske eseye komunike se un sin fos. Toujou gon rezon pou pataje ki jan ou santi yo. Paske santé mentale ou konte.
Welcome, everyone. Hi, Dr. Ojikutu. Thank you
Hi,
for
how are you?
good. Thank you for joining us. Thank you all for watching. For those of you who are not familiar with our guests, we have Dr. Ojikutu, who is the Executive Director of the Boston Public Health Commission, joining us for an amazing conversation today about the different things that are going on in the city when we talk about racism as a public health crisis. We'll also go into some conversations about the MassHealth reinstatement. So lots to learn, lots to understand, lots to gather, and a lot to share. So we welcome you and thank you for being here. My name is Brenda Lormill. I am the founder of the Haitian American Medical Association. I also practice at Mass General Hospital in the oncology department, phase 1 research. I am so honored to be here, to be chatting with Dr. Ojikutu. So I will not waste any time because I know there's a lot that we want to cover, but I want to jump into the conversation by having a basic definition. So we've heard the word or the term per se, racism, right? Structural racism. Can you just define that in the most basic way for us to really just dive into the conversation and get context?
Sure, and thank you so much for having me. You're right. A lot of people are using the term structural racism, and unfortunately, it oftentimes doesn't come along with a definition, and it's sometimes confused with other forms of racism, which I will also mention. Structural racism itself is really about systems. So systems in which policies and institutions create and then perpetuate racial inequity, socially, economically, and politically, and oftentimes this leads to poor health outcomes. When I say systems, I'm talking about the context of the world that we live in. It's not about what happens within an individual medical institution or within an individual academic institution. It's really about all the institutions. It's really about our entire system. And another way that I tend to explain structural racism, it's really about a system of hierarchy, privilege, and power that excludes non-white individuals and then perpetuates racial inequity. I hope that is clear.
No, that is very clear, and it's actually segueing into my next question. Is you use the word systems, right? So we talk about structural racism is a system. Can you give an example of how structural racism as a system can affect the health outcomes of an individual and even a community based off of the work that you do at the Boston Public Health Commission?
Well, I think there are a number of really profound examples that have been within our system for centuries almost. So if you think about housing, and housing both nationally and housing both locally here in Boston, we know that the U.S. has a history of racially biased housing policy. An example of that is redlining, and I'll define redlining. So it's another word that oftentimes is thrown around and then not really well defined. So redlining was a system of ranking neighborhoods by their worthiness for home ownership. So whether or not homes were increasing in value or decreasing in value. And essentially, the neighborhoods where Black people live were often deemed less valuable and less worthy for home ownership, and therefore mortgages were not given out. All right, so they were impossible for Black people, many Black people, to obtain. And without home ownership over decades, there's been a significant loss of generational wealth within communities of color, and that has led, in many circumstances, this issue of this history and policy of redlining to residential segregation. So, and you look across the city of Boston, you see that there are areas where primarily Black and brown people live, And then you have areas where primarily white and wealthier individuals live. And what happens within those neighborhoods where you have these sort of lower rates of home ownership, lower values in terms of the homes or the properties that are there, oftentimes those neighborhoods are under-resourced in general. So under-resourced in regards to healthcare services, under-resourced in terms of other services that may be provided. And if you look just at our housing, sort of challenges here in Boston, the quality and affordability of housing within neighborhoods across Boston is a challenge. So that's one example and one way to look at it. But we could also talk about discriminatory immigration policies. We could also talk about mass incarceration. We could talk about employment. It's really throughout all of the systems that we see across our city and across our country and beyond.
I love that answer, because we may look at housing as an issue, but then when we think about health, the health of an individual, if I can't secure a safe place to stay, how does that then affect my overall health and the health of my family, right?
Exactly.
I love it, because as a clinician, we look at these things, right? The person who's coming into the institution, we're caring for them within the four walls of the institution, but what happens outside of our four walls is actually what's determining how well their health outcomes are when we're caring for them. So I love the housing example, and thank you for using that as an example. As we use that and segue into health inequities, that's leading up to my next question. Before we get into my next question, can you define what health inequities are?
So generally, health equity is when everybody has a chance to live their best life, right? So that everybody has access to resources, everybody has a full a full life expectancy, or at least somewhat similar life expectancy across race and ethnicity. When you're talking about racial inequities, you're really talking about differences across people. You're talking about looking at a situation where amongst Black individuals, and I'll just give you some updated data. If you look from 2017 to 2021, Black residents in Boston experienced a 37% increase in premature mortality. That's across that time span. But there were no significant changes in the rate of premature mortality amongst Asian, Latinx, or white residents during that time period. So there's a clear inequity in regards to mortality and in regards to life expectancy. If you look at life expectancy in Boston, we know that the average life expectancy across all residents is approximately 81. But let's compare that to the life expectancy amongst Black males, which is actually more around 71. So these are the data that we know they exist, and they demonstrate pervasive inequities across our system.
And with that data that you guys have, and data doesn't lie, right? What are you guys at the Boston Health Commission, how are you combating some of these issues that you guys are seeing, some of these things that we probably have known for some time, but then there are other things that always pop up, right? How are you guys combating the health inequities that you're discovering in the city of Boston?
Well, I think that one of the ways that public health works in general is that we spend a lot of time, aggregating data, which is kind of what I tried to, give you just a snapshot of or a snippet of. And then we look at the programs that are offered. We look at the strategies that we're going to implement. And we attempt to sort of match the problems that we see in the data to whatever programs and interventions that we're hoping to implement. So, for example, within the COVID-19 response, we know that there was inequitable access across our city in regards to testing, in regards to vaccination, especially early on, right? So what we did is we prioritized equity in our response, and we removed barriers to accessing all of those things, accessing testing, accessing vaccination, accessing treatment. And currently we have standing sites for vaccinations and boosters in the areas where we saw those inequities. So we have a standing site in Dorchester, we have one in Nubian Square, Roxbury, we have one in Hyde Park, and we have them in more general locations, because of course we want to make sure that all residents have access. So that's one example, but there are numerous. So
Right.
we're all aware, during COVID-19 and after COVID-19, sort of what we're currently experiencing now in terms of sort of post the surges that we've had and the lockdown, mental health has been a major concern for people. And one of the things that we know has been a challenge is there's certainly stigma in regards to accessing care and treatment in regards to mental health. But then we also have a lack of mental health providers within our communities, both mental health providers that look like us, as well as those who are linguistically competent and able to, communicate with a diverse patient population. So one of the things that we've invested in here at the Boston Public Health Commission is a new Center for Behavioral Health and Wellness, where we are in the process of training a whole slew of healthcare providers who will be prepared and able to provide services to individuals coming from diverse backgrounds. So again, we look at the problem and then we try to find equitable solutions.
And the solutions are ongoing, right? Just
Yeah,
hearing,
absolutely.
right, they're ongoing. Some of us might feel like we're out of COVID, which is not true, right?
Right.
But the vans are still there, the sites are still there, the people are still there, the mobilization is still happening to meet the needs of the community. I know we're not at the end, but I want to take some time to just say thank you for all the work that you guys are doing around, how to support people through COVID and these post-COVID times. So, we talk about healthcare access to it, but there's something that's happening in April that's coming up, and April's in just a few days, the MassHealth redetermination, right?
Yes.
So we can find hospitals and clinics, but if we don't have health insurance, which is a mandate in the state of Massachusetts, how do we support our communities? But if we do have insurance, how do we keep it? Can you explain the MassHealth redetermination process so our viewers have a better understanding?
So this is incredibly important, and it's important that even if you're hearing this and you don't have MassHealth, that you spread the word. Essentially, MassHealth needs to renew coverage for all members, essentially determine eligibility on an annual basis. And that has just been a standard in terms of sort of the policies in relationship to MassHealth. During this period of redetermination, people who have MassHealth need to update their information so they can maintain their benefits. If they don't, then they will no longer have access. So this is sort of, again, just a standard part of MassHealth as an insurance source. During COVID, redetermination, so this checking to see if people are eligible, was temporarily paused. And that was important because so many people, either didn't have there was, obviously we were in a lockdown, people didn't have access. There were many issues that were ongoing, and certainly people weren't necessarily accessing our community health centers or other service areas where they may even get assistance in regards to redetermination. So this year, we will no longer have that freedom to not redetermine eligibility. So what will happen is that people will need to go through the process again. And think about it. If you haven't been doing something for 3 years and now all of a sudden you have to do it, you may not be as familiar with it anymore. You may ignore the notices that come in the mail. It may not be something that's at the top of your mind. And what we anticipate may happen is that a lot of people will lose coverage and then not have access to necessary health services. This is something we are really trying to avoid. We want to make sure that if people they have MassHealth, if they have received a notification in the mail, that they open it, and if it's not clear to them, that they reach out for help. And that's one of the things that we're doing here at the Boston Public Health Commission. It's something we do continuously. This is one of our longstanding services. We provide what's called the Mayor's Health Line. And we have people who are manning telephones, and they are specialists in MassHealth and in coverage and in making sure that people are linked to care. For all those individuals who either miss the envelope, the blue envelope that I mentioned, or if they have questions, or if they need to have somebody help them interpret the information that's in the blue envelope, this is where they should call. They should call 617-534-5050, Monday through Friday, 9 to 5. We have people who speak more than 5 languages. It's free, it's confidential, it has nothing to do with immigration status. No one's going to ask you those questions. It's simply there to provide you with assistance. So please avail yourself of that service. Please utilize it and spread the word.
Thank you. And for the process itself, is there a cutoff in terms, I know it starts in April, but is there a particular time frame that folks should be, reaching out if they need help by a specific date?
So once you get the blue envelope, that's when you need to be reaching out. Okay. This is going to be a long-term process over the course of a year. I do not know. There's going to be a due date that's on the renewal package. You will see that you will see that due date. And that is what you need to pay most attention to. And when you call the Mayor's Health Line, which is the number I gave you, 617-534-5050, they will help you figure out exactly what your sort of your time period is. If they're, and they'll help you address anything that has caused a problem. And if you've already tried to renew or had your eligibility redetermined, they will assist you with that process.
One thing that comes to the forefront of my mind is that in the past 3 years, so this hasn't been a process because of COVID, of course, but a lot of people may have moved and they might not even receive that blue envelope. So if you hear the number that Dr. Ojikutu just mentioned, and it'll most likely be at the bottom of the screen, don't hesitate to call that number, because if you've moved and the address that they have on file currently is not where you're living, you want to make sure that you're reaching out and updating that information as soon as possible, because your due date is on that envelope, and if you don't receive it, then you have a due date of today, right? That you want to call. You want to call and get that underway. Are there any other community organizations that are helping folks? I know there's HICFA, Healthcare for All.
I was going to say.
Mayan Budsman. Is there anyone else that folks who might be more comfortable to reach out to other community organizations that you can think of?
So many people have started going back to their healthcare providers, and our community health center partners. We have wonderful community health centers in the city of Boston. They are offering similar services. Boston Medical Center is offering similar services. MGH and Brigham and Women's Hospital, they're all trying to help. We try to augment that because the issue is that some people are not accessing health services than they need to, right? So we're trying to sort of fill in the gaps of all of the wonderful work that's going on in terms of what our healthcare partners are doing. And certainly Healthcare for All, as you've mentioned, is a wonderful organization that's doing an enormous amount of work.
Yeah, I will say for our Haitian community, we're working on getting that information in the Haitian Creole language over a live stream, so that will be available for folks to understand. And I love it that you had mentioned when they do call in, there are folks who speak different languages who can assist. Sometimes folks do not engage because they're afraid of that linguistic barrier. So if you're listening to this, share the information with your loved ones, with your community. Know that there is help. We do not want you to have a lapse in your insurance, because that is also your key to accessing care as well. Dr. Ojikutu, any closing remarks? I know we're coming right up to time, and I just want to thank you for sharing everything. Anything you want to share with folks who are listening?
Well, I think one of the things I want to share is that we at the Boston Public Health Commission are a resource. And there are many programs that we have out there, but if there are things that you think that we are, not doing, or things that you would like to see happen, then reach out. Let us know. Send an email. We have an info line. We have, people who are out in the street. You'll see us, at different events. We want to be here to serve. Our goal, our mission is to, meet the needs of Boston residents. And that's what we're here to do. We have a lot of programs that I think oftentimes people are not aware of. We are going to try to do a better job of letting people know the services that we provide. I think that's one of my goals since I've started in this position. And so maybe you'll see more of us out in the community also.
Well, I have to say thank you for all the work that you guys have done. And thank you for the work that is to come. And thank you also for your time this morning.
Thank you. I really appreciate it and look forward to potentially talking again.
Awesome. Thank you.
Take care.
Paske li oke pou pa oke. Paske pale kapab ran bagay yo miyo. Paske essayez communiquer, c'est un signe force. Tout toujou gon rezon pou pataje ki jan ou santi yo. Paske, santé mentale ou konte.
Hello viewers, my name is Emeka Agudila. I'm a medical resident at the County Hospital, internal medicine. I have background in health disparities, and this is part of our lecture series on health disparities. And today I'm going to be talking with my very good friend, Dr. Bonnet, who has been in the forefront of providing primary care services to residents around here in Boston for over 30 years. And today we're going to be discussing health disparities in general and how it impacts people of color and ethnic minorities in the U.S. Welcome, Dr. Bonnet.
Good morning, Emeka. Again, it's a pleasure to be with you. I know your passion about the issue, and I'm being a public health person about health disparity. It would be my pleasure, really, how far we could go in depth on this matter.
Right. I know you have been on the front lines in terms of providing medical care and clinical care for patients. What is your general take in terms of health disparities, especially among ethnic minorities in the United States?
Well, health disparity has been a real issue, real concern for healthcare system and for society. Nevertheless, it's hard to say it's a very complex matter. Since 2010, we had that program with doing Reach 2010. So we talk about this and how we need to at least flatten the curves of health disparity. And since we're not seeing too much progress has been made, health disparity is very complex because it's not having only the implementation of public health. You cannot implement the policies of public health without patient participation. So to understand it, you cannot leave the patient behind. The patient has to be part of the process. The question is, how you bring those group of patients, which most of the time are marginalized and sometimes self-marginalized because immigrants sometimes they live in their bubble. How you make them part of the process really to make that change. I don't think any real change could ever occur unless the affected group participate in the process. And this, they must cross the bridge of education. So it's a complex matter, and I would say sometimes neglected by the system. Let's say, for example, we know prevention is at the basis of everything. If we look at the healthcare system, that $1 trillion industry, if I could, no mistake, 3.4, recently I read in 4.1, 90% of that money goes to chronic disease management. So you wonder how much is put for preventative care. That's a real matter. And have we seen a good understanding of the ethnic minorities? That's a very complex matter. Being a public health person, I know they are at the forefront in how to resolve the problem of the country. Do you think you have seen, by policy and other things, any integration of this group to solve the matter? I don't think so.
So what I'm hearing is that over like a decade now, despite all the interventions and efforts and all the policies, the disparity gap has not narrowed.
No, no.
And also, we could say that the causes are very multivariable, multifactorial. So from your experience, as someone who has been in the front lines, what are the things that we should be doing differently now to ensure that this gap becomes narrower over the years?
As I stated, we cannot leave the patient behind. Everybody think about patient-centered care and all this. And now we're talking about social determinant of health. We cannot resolve it only by multiplication of service. As a matter of fact, it could be dangerous because dependency never play any role in progress. Empowerment could make the difference. Now, is the system there to empower and allow this group of patients to be integrated to the system, understanding the healthcare system, which is so complex by itself? And also, because when we talk about crossing the bridge of education, which should be done by providers, the question, are the providers themselves, are they in tune with the reality of the patient they serve? Because believe it or not, if we look at the demographic, it's changing and make it more complex. Because every single immigrant coming to this country bring with them their laundry bag. Laundry bag which is not washable by the first generation. So therefore, understanding them, it's very complex, and they're living in their bubble. If you cannot penetrate that bubble, it's not that easy to educate, because that laundry bag include their language barrier, their illiteracy, their socio-political things, and all those, they bring that with them. And when they come to the country, what I usually say, they pick up their survival kit. What I mean by, they got their church, their grassroots organization, their supermarket, their barber shop, and all. They are living in their own world inside America. They are living in an island with no bridge to the mainland. So therefore, when we talk about issues between people, those people, and the policy that we have, those policies not necessarily reach out to those people. It's very complex. So I think providers, public health, and so have to step back, make an analysis of what they have there as tasks, which is, I believe there is solution to it, but they have to be part of the process.
Interesting. So basically, what I'm hearing is that there are a lot of complex issues involved in this. I just wanted to talk a little bit more about, you talked about empowerment, for example. Empowerment means different things to different people. It means different things to the providers, different things to the patients. And you also talked a little bit about, how patients tap into the social network in their own environment. How does the empowerment and the healthcare system integrate into the social network system that the patient have at the grassroots level, at their own bubble? Is there any kind of connection or integration between these two separate systems? And how is that going to happen from your perspective?
Oh, I think it's not that complex, not that easy. The question is the status quo, the power to be in the healthcare system, understand it the same way. They are willing to allow that integration to take place to empower the patients so they could really play a role in their health. First of all, we have to see the patient in the human aspect. In the human aspect, patients have a tendency to really see disease as symptoms. So when people are seen that way, you cannot really talk about prevention, because if they're not symptomatic, let's say somebody coming from a place where they don't have any healthcare system, the insurance is an issue. Their understanding their health belief is an issue. Are they at the symptomatic level of disease, or they understand the pathology? Some places, if I take to be more specific, some people will see they still at the hot and cold and gas theory, the old Chinese things. So therefore, if they have the flu, they got a cold, they're not going to navigate, is it COVID? Is it a pneumonia? Is it no, it's a cold. They're going to look at hot thing to use hot to fight against cold. They may having a chest pain and they think it's gas while they're having a myocardial infarction. So if they don't understand what is at stake, because this is their health, they're not going to react to it. Let me step back, talking a bit about my understanding of it, of the triangle of life. Health is in the triangle. Life, I would say, you got the spiritual, health, and wealth. Spiritual, health, and wealth. And they're all intertwined. So nobody could give that to anyone. You have to earn it. And it's never been stable. You always have to work on it to improve it. And this is the responsibility of that person to do so. You cannot really take people out of poverty without themselves. They have to participate to the process for them to really accumulate wealth. So it is for health. So when they understand that, they participate. So we are providing what we have to do. We have to educate people for them to understand. And that coming from generation. Yeah, let's say we have, for example, a good 60% of the nation obese. But we have to go to the source of the matter about their diet and exercise and so on. But what do they eat? There is sometimes a conflict between the wealth and health. You have to balance them. And sometimes that conflict is not what person can do, the way they eat. There is culture involved on it. It's very complex. But we have to create a model for people to take charge of their destiny, starting how the parents raise and so forth. We understand some of the issue could be environmental, responsible for government and society. But a lot of part of it is really behavioral. And that behavior starts from childhood. You have to understand, you have to get the education, and you have to get the means to make the best decision. So if you're looking at the patient part, it's multifactorial too. And we're looking at the relationship with the patient and the system is multifactorial as well. So, but those are known entities that we know. Now, we're talking about, for example, social determinant of health, which is a very good matter if you want really to be very successful. as a resident, you are in the hospital taking care of patient. The patient coming bad, you put on the unit, you get this, and they get better, and you send them home. But if you're not analyzing where they're going to, what kind of support they have at home, what their condition, are they incontinent of what, stool and urine? Are they able to ambulate? Are they, so the outcome, whatever money you spend in the hospital, is good for the hospital after upon discharge. But when they go to the community, they're going to fail unless you address those issues. So it's very, I'm not saying complex because you could understand it, but do we put everything as public health for those people to succeed? And I think we are in the maker of medicine. We know that in the world, we are on top of the world on this matter. But I think we imply so much on the bio, but in the emotional, and the psyche, and other social issue, I don't think really we doing too good. We see the ramping in mental health. We see all those issues. And so they don't start from where, they start from below. Any disease don't, by the time you get the disease to occur, it takes substance at the beginning. So we know about it, how that causes it. But do we address it? That's another issue.
Right. So in other words, you are saying that we need to go back to the grassroots. We need to address the social determinants. We need to do more about prevention. And this involves educating the patients. I know you have been doing this for a very long time now, and you're working with a lot of community organizations. What have been the challenges that you have encountered, working with different communities, and also in their efforts to integrate these preventative measures into the healthcare system?
Everything in society require, we're not talking equality and anything, that do not exist. But we need balance in society. And for that balance, for that equilibrium to occur, nobody above going to give it to you. You have to work for it. And it start, like Tipodin said, it start to be local, in the family, in the community, and grassroots. And to understand that, getting engaged at all levels, to really create that equilibrium, either at all levels in health and wealth. Because health and wealth are the macro working together for a society. Look at what COVID do to the economy, due to the wealth of the people and the impact it has on the economy. Yes, some people will benefit from it as well. That's the reality of life. There's nothing wrong. That's what it is. But the first person, the individual, it must start with the individual to know how to protect himself and how that individual protect himself and protect the family, protect that community, and then protect society. We all together, but it starts from below. So sometimes, we try to start it from above, and forgetting the grassroots organization, forgetting the community, forgetting all this, and they think they could affect it. It cannot occur. Yes, above, they may take the decision, but we have to go to the bottom with people, individual, get them involved, and how they could raise up and to create a better network inside to serve society.
Great. So, you talked a lot about the relationship between health and wealth. In my experience, I've encountered a number of patients who are not able to afford the care that is being provided to them, either because they don't have adequate health insurance, or there are some other issues that they are going through that prevent them from either buying the medications or affording to pay their copay and every other thing that they need. Even getting buying a good diet, healthy diet, fruits and vegetables becomes impossible for most people. Do you have any suggestions, especially for low income, people of color, immigrants that are struggling with these financial challenges that indirectly impacting their health?
It's very complex. Let's say, for example, insurance. I think government doing their very best and so make sure trying to see if everybody could be insured. Obviously, for those who work and trying to get insurance, and because there's a conflict between the tab they're going to take, either they're going to take the premium and all this, they don't understand sometimes what deductibility is about. But once you got that deductibility higher, is cheaper for them, they got a tendency to take it cheaper. And if you tell me before the insurance pay for you, you have to really offset your deductibility, which is so high. So that keep people out of the system, out to not to see their physician, and so because they don't want to afford that. And sometimes that the same health insurance got limitation of what medication they cover and not what they not cover. That's another thing. People don't understand the Medicare system. Do they understand that Medicare A and B don't pay for medication? And do they understand the process, the Part D for medication or supplemental insurance for the 20%, because Medicare, whatever you go, will pay 80% and the 20% will be on your responsibility. That 20% is so much for other people, is their lifetime, whatever they have available. So government understand that if whatever you receive in Social Security or Social Security disability, whatever, if you are eligible, so you could have Medicaid. But some people don't even understand that. Even they qualify. The Medicaid not going to call you to provide that. You have to understand it. So for you to apply to have that Medicaid. There is so many, this is so complex in the healthcare system. For those, as I say, living in the country, those ethnic minority, as we talk about the living in their bubble, they're not really fully integrated to understand how the system works. They are marginalized and self-marginalized. So those are really deficit, those gaps to fill out first. Also, talking about insurance, we still have that dichotomy for those they have and they have not. This is because it's talking about health, which is, in this country it's talking, is it a privilege? Is it a privilege or a right? So that's another subject that we have. So the healthcare system per se is complex, but we are dealing with life, we are dealing with human beings. So this need to be addressed. And unless you start it from bottom below, we're not going to be able to really make a dent or flatten the curve of that health disparity.
So my experience, I've worked with quite a number of patient navigators. They call them different names in different hospitals. Some places they call them case managers. But these are people who assist patients when they come into the hospital, when they interact with the healthcare systems, to probably educate them on what kind of insurance they might qualify for. Have you worked with these kind of healthcare providers to assist patients? Because we know that patients, best place to catch these patients are when they interact with the healthcare system, either they present to the emergency department or they were admitted as inpatients. But, helping to educate them on what they might qualify for and, what all these types of Medicare insurance mean and how they can, tap into these resources and help themselves out. Have you done any work to, see that ensure that this works for patients?
So the social workers, healthcare managers, and all this, and so they are blessing to the healthcare systems, try to integrate those people and get this. But again, we're talking about barriers. There's some barriers. We're talking language, culture, and all this, and all this play a role between the provider. At this point, we talk about the social worker or the people when continuing care and so forth. And sometimes the new generation just coming to America, and they're the one they are on that predicament in that situation. So sometimes they are there, they're talking, but they're not talking. Because the level, you have to bring to the level of the patient for them to understand. Remember, they come from a place where what you're talking was non-existent. And also a place where you ask them to be part of the process. Sometimes they come from somewhere, somebody decide for them. It's a different environment. Some places you go, since the patient go to the hospital or to see the doctor at the last minute, because they're on the symptomatic level, it's not for prevention, they come when thing is already really way over the matter. So, and physician on those countries has a tendency to talk to the person who bring the patient to the hospital and leave the patient way behind, which is not the system here. The patient have to be part of the process. Now, how you ask them to be part of the process, this is a policy to respect patient rights and all this and so forth. When the patient himself is not in tune with the reality, and you cannot really educate them about the matter. It's very complex. So we need a real, I would say, interaction with patient, education of patient, and understand what the healthcare system is about, what they're entitled for, and how they could really navigate to that complex system. There is another thing. I used to say communication is destroying, is the jargon, destroying communication. We are at the era of technology. The second generation is in tune with it. But the first generation really are falling way behind. And with the speed of technology, they're falling farther and farther behind. So the expectation, I'll tell you, okay, what is your email address? Does all my patients, how many of my patients got an email address? And so, commonly, you could go in the portal to this. How many could do that? So, as we advance in technology, I think we have to also create a support system for that group not to be left behind. Because I maybe in 20, 30 years from now, we will be a different reality. Although newcomers will come, but how you integrate them as they come to the system, not creating that dependency. It's quite complex.
Interesting. So, in other words, like, being more culturally sensitive, understanding the patient's background and, fine-tuning the healthcare system to align with each patient's background and experience, kind of tailoring the health system. Have you had experience working with providers in terms of, something like cultural competence or language proficiency training, to help them interact with patients from different backgrounds?
Yeah, actually, at the Kano Hospital Residency Program, we understand the value of this, and Dr. Morgan, the chief sponsor of the program, the chief of cardiology as well, is really in tune with that reality and trying to mold it to that fashion. And some of the residents, as you know, go to my clinic just to be exposed on different culture and living the reality of outpatient medicine versus inpatient care. So these are a very important step, which really could bring some a level of approachment, I would say, between patient and providers. But however, we have another obstacle. Where there are technology, the EMI, all this, so sometimes we spend more time documenting, and instead of talking to the patient or seeing or understand who's the patient and talking face to face, understand the patient. Now, we understand it's not a simple thing, because the system will ask you, I give you only 10, 15 minutes to see a patient. And you ask yourself, how in the world I could really accumulate all those data and seeing the patient, not only the pathology that you're looking for, but see the patient itself, the person. Who is that person? How many times the pathology is secondary to emotional factors? How many times it's secondary to the cultural factors? How many times we misdiagnose because the way we didn't have enough time really to talk to the patient and listening to the patient, and become a very complex matter if you cannot speak the patient language, or you have interpreters. Sometimes it get diluted, and what is it? But funny enough, despite that, if you engage to the patient understands it. You establish that rapport between you and the patient. And so listening to the patient for little it could provide to you. That really create the construction, the edifice of that relationship that you want to create. And sometimes this time is completely absent. You could have well documented, but that relationship patient with the patient, which is at the core of all what we're talking about, is completely absent. So it require this to be studied maybe at medical school and residency program to understand that patient is a biopsychosocial entity. It's not only the bio, there is interaction between the three. How we really see that and care for the patient in the three-dimensional fashion, not really looking as nothing against the surgeon. You got an appendicitis, you remove it and you're done. That's not the case for primary care. We have to deal with the patient and the full entity. Obviously, you need complementary service. You need social service. You need other providers. It's a teamwork to be able to understand who that patient is and to be effective.
So it's kind of multidisciplinary approach.
That's correct.
To caring for the patient. My other question for you is this. Do you have a system of following up your patients after the clinical encounter? Is there anyhow you follow them up in their environment, in their society, to see how they are doing in terms of the psychosocial aspect that you talked about?
There is a relationship between the community and the clinic, wherever that patients are. That is sometimes missing, most likely for community institution. Sometimes, yes, you use your EMR, you note and so forth, relationship calling, and also keeping interest, follow up. Education must play a role. Sometimes I understand you cannot educate quickly doing that, but we have to create a model to follow up and educate, to reinforce, either for compliance, either for understanding the medication, and all what thing they don't that get used to, how you get them into this. But I think it do not work only at the clinic. What we are doing here today is because source of reflection. Because those who are outside in the community, those of you who are listening right now, must really ask them a question: where do I fit on this? Is really this matter relevant to me or to my family, to my kid, to my this? Because at the end, it's not when you go to the hospital the problem starts. The problem always exists there. It grows before it explodes. It's like people with coronary artery disease. They don't come overnight, they get a heart attack. Things has been built up endoendothelium. It's been built up subendothelially. It's been built up. So if there is a method that was used to really identify, to really even primary or secondary prevention, I'm pretty sure costs, but also the numbers where we are today won't be there. Let's say, for example, we know actually, which is another discussion, we have about 37 to 40 million people with diabetes, which is the entry door. We play a great role in the leading cause of death in coronary artery disease, include hypertension, dyslipidemia. They are dealing with it. Good medication on the market right now. We know that 50% of people with diabetes, for example, will get coronary artery disease, and so we're going to get 35% probably will have a kidney failure. But now, the academia and corporate are working together to come out with best medication, how we could really maintain the disease management. That's great. But the caveat is we have 96 million people coming with prediabetes. What are we doing with it? And amongst those, 84% of them don't even know about it. And unfortunately, most of those people fall in the ethnic minorities. So, it's mandatory for those of us, providers, who have the chance to understand the multicultural facet of it, all those different barriers, you understand that. It's up to us to create. It's not that people sometimes, academia cannot say, oh, I'm ignorant. It would be the sky will be falling if academia say that. Because they're responsible to legislate, to do everything. But part is very complex. So it requires that layer of society, ethnic providers, to really get engaged. Because we're part of the bubble too. We're able to penetrate the bubble. We're able to educate them better. So it's our responsibility as providers to get engaged, to better educate, to integrate them to the healthcare system.
Paske li ok pou pa ok. Paske pale kapab ran bagay yo miyo. Paske, eseye komunike se un sin fos. Toujou gon rezon pou pataje ki jan ou santi yo. Paske, santé mentale ou konte.